Anybody else?
I want to second that statement. I think that we've all focused on the greater good of the patient, and although we do it in different settings and different means, we both try and make sure that we have the most up-to-date care and that we deliver it efficiently and safely at all times.
Okay. What about in terms of other aspects of the job that you think not necessarily for the two people that spoke, but maybe somebody else, what are something else that combines athletic training and physical therapy as professions? Or similar overlap in terms of skill sets?
So I'm coming at you live from cheer practice, so sorry that you can't see my face.
It's okay, too.
So I think another thing that connects the two professions is musculoskeletal injuries. Now, not that that's the only thing that we see, but it is a common ground for both of our professions, and how we kind of specialize. So I know that there are definitely different realms and nuances as part of our profession, but I think that's a big thing that connects us.
Anybody else?
I'll talk.
Thank you.
Yeah, kind of along the same lines, physical therapy has kind of a wide span of things they see, so does athletic training. So even though there is some overlap with that musculoskeletal, I think we each have different specialties within our own realms, but I feel like those scopes are equally matched, just kind of in different directions.
Yeah, so I think those are all great aspects about how we generalize what we think an athletic trainer or physical therapist may do. And so typically, this may be from lived experiences working with each other or talking to each other, but if you haven't actually, like Devin talked about, if you haven't worked with someone, you may not know what they're actually capable of. And he was talking about his past relationships, and those really change your experiences with someone that's based off that. So I wanted to do this quick activity because I'm going to talk about some negative aspects of collaboration as we get going, but I want to make sure that we also take a step back to look at common likes, dislikes, and things that bring the two professions together. So if we look here at the team-based competencies, to be able to be effective at collaborative practice, there's 7 competencies that essentially describe team-based care. Adaptability, team leadership, you can see the rest there. I highlight a mutual trust one because I think it's the guiding factor that has to be there, and should be the one that basically decides who you're working with. So if we take the collective orientation first, when you decide to do collaborative practice together, it's key that you both have the central mission and vision of your organization or your patient care understood, and that you both go through the same process of the roles and responsibilities of who's going to be doing what in the collaborative network. After that, someone's got to take a leadership role. So if everyone takes a step back and says, we'll just figure this out, and no one actually makes the conversation begin, you actually don't get anywhere. And so teamwork never starts without someone being the leader. But at the same time, being a leader doesn't mean you're not assessed. And so mutual performance monitoring essentially says that regardless of who's the leader, that the team as itself will mutually assess each other to monitor that their performance is happening, and that they're meeting their end of the bargain. And that's where that leads to backup behavior. So if someone is really skilled in an area, but they are not highlighting that, but the team member on the other side knows that that person is capable of that area, that's what a backup behavior is. Essentially saying, if I know that Sadie is really skilled at doing manipulations or mobilizations, and she's not doing that as part of our collaborative patient care, I need to do a backup behavior and say, hey, I know that you haven't been doing this, but I really would like to see you begin to do this. And then closed loop communication. So often we talk about open loop communication in terms of continually getting feedback, continually making changes, and doing continuous quality improvement, which is key to being a healthcare provider. But closed loop communication is kind of looking at it from a different angle, that to have change happen and make sure that it's actually done, you actually have to deliver feedback in a way that makes change occur. So it has to be something that's delivered and achievable with an end goal for that to occur. And finally, adaptability, I think is key, that often we get prideful about our skill set or who we are as a healthcare provider, and that when we get questioned, we often feel like, or if someone asks us a question, we feel like people are questioning us as a person rather than asking us literally if they just don't know. And so often we need to adapt to who you're working with on a team to say, are they really questioning my skills, or are they just questioning because they don't understand? And that, I think, builds that mutual trust together. Anybody have any questions or comments? Feel free to talk throughout this. So if you have something, you can write it in the chat, unmute yourself, feel free to engage with us, okay? So if we look at the history of AT and PT together, we've had to deconstruct the negative stereotypes of both professions. So as some people in the DAT program here at Indiana State know, we have one of the oldest athletic training programs in the nation. We were one of the first 4 professional programs and one of the first 2 post-professional programs. We've been around on campus for over 50 years. And that's been an awesome thing that we've highlighted throughout the program. The PT program is pretty new, but being successful here at Indiana State. But the profession of PT has been around a lot longer than athletic training itself. So athletic training is a pretty new profession, and coming into the world of all these other careers such as OT, PT, PA, we've kind of had to deconstruct the negative stereotypes, and that goes mutually with each other. So what really is an athletic trainer and what really is a PT, and breaking that down. And that has led to improvements in confidence to communicate across professions, continuation of interprofessional collaboration across the lifespan, and changes to the scope of practice, though, have really started to ignite that conversation about negative stereotypes again, or the idea of you're stealing my patient panel. And that's what really led to some hostility. So if you aren't aware, back in 2008, the NATA, which is the National Athletic Training Association, that's the member organization for athletic training, actually sued the APTA, which is their member organization. It was about violating antitrust and fair practice laws that basically PT was not being nice to AT, and we got our feelings hurt. And so we sued the APTA. It actually didn't play out to a ruling, but the new president in NATA for the NATA in 2009, who was an ISU alum of our athletic training program and was the president for our national organization, made a big statement 10 years ago that said she was devoted to change and saying we have to start collaborating together. So fast forward 10 years, and in 2018 in December, the APTA and the NATA released this statement in December 2018. Essentially what it said is, we need to collaborate better. So 10 years later, we're saying the same thing we said in 2009, and we still haven't gotten anywhere regarding PTs and ATs mutually collaborating together regarding patient care. And they really highlighted 6 key areas here. So educating the public, promoting the education and training of each profession, collaborating together on your services, encouraging leadership, specifically with youth sports, sharing best practice models, and collaborating to highlight the value of both professions. And so Tori Lindley and Sharon Dunn, who are both presidents of both organizations, made this statement in December. And if anybody in athletic training on the call, in our recent NATA News, which is our membership magazine, released another statement about this collaboration. And one of the key statements in there was, if this happens. And I think that was interesting to see from our president, where they released a statement, they want to do this, but they also said, if this happens. So we can talk all day about this happening, and this can be a game changer in terms of how this conversation starts, but someone has to do it. And I think that's what Dr. Hauser and I and Dr. Eberman, the program director from ISU, the DAT program, really saw that we have to do a good job of making these experiences in the curriculum for you both, to make sure that you see what it's like potentially as you move into your career. Anybody have any questions or comments about anything we've covered so far?
Zach, I just wanted to say is that I truly appreciate you bringing this topic up, because I know my students hear this a lot, but as a former physical therapist in the military, I mean, collaborative practice was essential for the success of the patient. And I'm glad that hopefully, this can come in the civilian side as well, as we're working together collectively for the patient. So thanks for bringing that up.
Yeah, definitely. I totally agree. And I'll touch on some of that Dr. Hauser just talked about too, about some setting specific places too. Does anybody else have any reactions or emotions as we start going through this, or something that maybe came to your mind as we approached the kind of conflict or the background of this?
I guess I was I was a little surprised by the lawsuit. I actually didn't hear about that, even though I started my athletic training education in 2012, so 3 years after the lawsuit. So I guess I was kind of surprised to hear about it, but it was very interesting to see the progression over the last 10 years.
And I think it's important, regardless of if you're a second-year PT student or been practicing for 50 years, or same thing for athletic training students as you move through, that it's important to kind of look at the history. So we can sit here and say collaboration should happen and it's going to be great, and we can try to put on this wonderful front, and then you may go to your clinical site or go do your patient encounters with your preceptors, and then they say, that's never going to work, or that's not in the real world. And so I think it's important to make sure you understand why. So if you're working with a seasoned clinician, that you understand that if they have limitations or concerns about collaborative practice, specifically the ATPT world, this may be the reason. And so to kind of share what I shared with Dr. Hauser was when I went through school, so I graduated my undergrad in my professional education in 2013. So right around the time of this lawsuit, so that entire first 4 years after that whole thing was playing out was when I was going through school. And the whole process was, we were told PTs they don't like us. They won't ever talk to you. Don't feel like it's going to get anywhere. So I went through school thinking PTs don't like me. So I was defensive of my relationship with PTs that entire time. And if you talk to athletic trainers that are my age or older that have been out of school 5+ years, we all kind of have that same scenario, that same conversation that we can share, that we were all told that this was what happened. And so we all were modeled behaviors that basically weren't necessarily true, but we also weren't given an opportunity to talk to somebody from PT to actually have that conversation. So the need for collaboration is there. And I think it's really important that we discuss what that looks like. And so when we get into collaboration, if my screen will change. There we go. The interprofessional lingo is really confusing. So I want to break these down in case you're reading articles or you're hearing people talk about it. Interprofessional education is essentially learning about, with, and from another healthcare provider. So that is specific to your professional or post-professional education or in your continuing education. Interprofessional practice is where you work in a team of clinicians that practice in the same environment. For example of this, in the PT clinic downstairs on the first floor of the building, they just hired an athletic trainer that's going to be working in there. And they used to be, for the people that haven't been here for a while, I've been here for 6 years now, but that haven't been here for a while, there was the whole time an athletic trainer working in there alongside the PTs. But that doesn't necessarily mean they're working together. So they practice alongside each other. And then interprofessional collaboration is the actual combination of healthcare for a specific patient with multiple clinicians guiding that care together. So practice and collaboration are a little bit different in terms of what that looks like. And so if you see the terms IPE or IPC or IPP, make sure that you can see that. So some people are asking some questions in here. Is some of the issue with the way PTs can bill AT services? So it's a really good question. That is specific to an AT our PT can't bill for an AT service. The only things that are profession specific are evaluations and reevaluations. Everything else is a code that's not profession specific. So an athletic trainer can bill, and those are things that I think we'll touch on as we go through a little bit later regarding how that looks like in practice rather than collaboration. But specifically in Indiana, athletic trainers have billing rights to over 96 third-party insurers, but we are not recognized by Medicare and Medicaid, which limits the amount of work that we can do with some patient populations.
I'm glad that you mentioned that, Zach, because I think some of the issues is that, again, CPT codes are not for a particular profession. So again, you have athletic training evaluations, you have PT evaluations. But if we're looking at therapeutic exercise or manual therapy, not one profession owns that CPT code, if you will. So that's definitely something to think about.
So as we move into what it looks like for collaborative practice together, the main 4 areas are shared decision-making, understanding one's roles and responsibilities, communicating patient-centered goals or conversations, and then a team dynamic. So these type of things are the competencies, and we have to ask ourselves, how are we accomplishing them within our professions and our programs? So our ethical practice and our values of each are typically guided by either a code of practice or a standards of practice. So what does that look like for physical therapy? Maybe one of the PT students, if you could answer. So what guides the ethical practice of a physical therapist?
First concern we usually worry about is the safety of the patient at all costs. So that's just one way to get it started.
Do y'all have a document that tells you what ethical or legal practice looks like?
Yes, they do, and they should. They should.
Am my thing working now? I was having problems with my audio.
Yes, it's working now.
Okay. Well, yes, to answer Dr. Hauser kind of answered it. We do have a document. I don't know that we necessarily have looked through it and read it, or necessarily know how to get access to it, but it's definitely available.
Good. And then for the DAT students, what guides ethical or legal practice within athletic training?
So the BOC Code of Ethics and our Standard Practice Act really guide what we should do and how we should kind of do it on a daily basis.
Right, so we have our Code of Ethics from the NATA, from our member organization, about what the ethical athletic trainer looks like, and then you have your Standards of Practice from our credentialing organization. So those both kind of guide your decision-making regarding the values and ethics of care. If you look into those, they talk about things like gambling or not drinking when you're doing patient care, things like not billing for services that shouldn't be billed for, and those type of things that really guide who your decisions are, that any competent healthcare provider should be. But if you take a look at those for AT, PT, OT, whoever it may be, they often overlap in terms of what those values and ethics should be.
I wanted to say really fast too, some of those are dictated state by state as well, not just necessarily a national law, but it can differ state to state.
So then if we start looking about what it looks like to actually work on this team together. So a disciplinary team is essentially people from across healthcare discipline working together. So working about or learning about expertise, background, knowledge, and values. So outside of school and forced opportunities like this, it may feel awkward to talk to someone about how did you get here, or what did you do to end up in this setting, or what are the things that really guide your practice or your background of why you do things the way you do. Those typically come from guided conversations and relationship development. But if you're working on a team together, that's a really key thing to ask the person that's working alongside you, especially the values piece, to make sure that that person has a shared value amongst patient care. We may assume that all healthcare providers want the best for our patients, and I think we try to exemplify that here at ISU. But if you're working on a team together, it's really important to really find out what's guiding them as they do their patient care. And learning that role and process required to work collaboratively. So the roles of each people typically get defined in someone's head, and the processes to do it are assumed. And so we may think that a PT is going to do this, and the process, once we transfer care, looks like this, but we may not have talked to anybody about what that looks like. Or after they get done doing PT, say for a long-term ACL rehab, and they send them back to the athletic trainer for return to play progress on the football field, we may say, the PT may think, we know what the AT is going to be doing, we understand the process, and we understand their role so they can do it. But we may not know where that collaboration ended or that patient care ended for that next step to take place. And so that's where that communication comes in, but also delegating tasks. It's such an awkward conversation sometimes if we all just assume that the person knows what's going to be happening. And working collaboratively doesn't necessarily mean just one person than one person, but it's also working together at the same time. So how do you delegate tasks without sounding rude or being cautious to tiptoe on each other's or step on each other's toes? And so there's some really good medical literature regarding this about collaborative practice on delegation. So often healthcare providers are afraid to say something to the other provider because they are worried that they're going to make them upset. And so one of the best pieces of advice I can give you is to talk early about what that looks like in terms of how we're going to talk about what we're going to do together, but also delegating tasks without feeling offended that someone asked you to do a certain task. And then providing accurate and timely information to each other, just making sure people stay in the loop regarding that process together. And then customizing care for smooth transitions. Dr. Hauser and I both believe that when you're working on this team, that smooth transition from one to the next provider or you working together has to happen across settings and time, but it's also regardless of physical location. So if you're placing someone in the clinic and then you're having them to work the next day outside and they're coming back to see you, and it's not just a transition of care, but it's also continuity of care throughout that treatment cycle or that plane of care, that you have to understand how that ebbs and flows of who's going to work now, who's going to be the lead, who's going to listen more throughout that process for that continuity of care, which is the ultimate goal for collaborative practice. And then the last two bullets here are resolving conflicts and in a shared language. One of the best things and worst things that I went through, I had Dr. Tiffany Idlewind, and she taught my manual therapy course when I did my master's degree here at ISU. And I had no clue sometimes of the language she would be using and that she talked in PT language. And then we would document stuff for class, and ATs document a little bit differently than a PT would. And so we have some abbreviations that we don't necessarily all use. We have some lingo that necessarily changes by your patient panel. And so really having a shared language in terms of what are we going to try to accomplish, and what does this look like in terms of medical documentation and working together for continuity of care. Anybody have anything to add about any of these kind of bullets on working on the teams together?
I do.
Yeah.
Okay. I'm actually right now working with a 2-stage ACL patient who's going to PT, myself, and strength and conditioning. And that's the first time I've ever had a patient see a physical therapist, period. So at all of my previous settings, we handled every postoperative patient from start to finish. And I ran into it today where I was like, I really don't know where she's at in PT. And I had a brief moment of like, well, just ask the patient. But we all know that that might not be the most reliable source of information. So I actually went across the hall, and I was so nervous because I felt like they were going to think that I was questioning them. And I was like, okay, hey, can we just talk and chat about where she's at, what she's doing with you? We can have some continuity. I brought the strength coach with me, and I was like, let's all just get on the same page. And the physical therapist was actually extremely receptive to that, and literally was like, if you have any questions, feel free to come back. You can come to a PT session with her. Like, I'll come across the hall, whatever you need, so that we're all, because she's going to be in rehab for 9 to 12 months. Like, we all need to be on the same page. And it was just a really positive experience. So I think it's definitely possible to have those positive experiences. You just can't operate on being afraid of starting that conversation.
Yeah, I think you bring up a great point, Kim. Sometimes it's not always resolving conflicts, but it's also creating the conversation the first time. And it's awkward. But I think you discussed a really interesting aspect at ISU. So I was talking to some of our students previously, our professional students that are in the master's level. And I said, how many of you have actually talked to another person from another program before here? And so I challenge you to think about that too, especially for the students that are local in Terre Haute. And you see the PT students, everyone's gathered on the second floor, and so everyone sees each other, but no one actually talks to each other. And we have this wonderful setup at ISU to actually have a conversation. So it's not necessarily we need to resolve a conflict, but we need to start that first conversation with people. And that's what Dr. Hauser and I think is one of the big take homes for tonight, is that now that you've seen each other, I know you have to kind of scroll through the 46 pictures to find somebody on here, but now that you at least know that someone's part of a program, that you may chat with them in the hall or talk to them about how school's going and those type of things.
And I think another big thing is that we have to stop assuming that we know what other professionals do and we know their scope of practice. Instead, we need to actually learn from each other and actually talk about, what's your skill set? What do you feel comfortable with doing? And in that way, we can have that collaborative practice and ultimately success for the patient as well.
All right, so I'm gonna have some questions for the group. Maybe like 1 or 2 answers per. But what constitutes IPE for you? What in your experience, maybe your previous clinical education experiences, what constitutes IPE?
I think one of the biggest things that I find to be like confusing for me in regards to that is like, to me, IPE initially was always like just the simple communication. So if there's a patient that I'm working for that is going to a physical therapist and I'm talking to the physical therapist about, what they're doing with them, and then like potentially like what care I guess I can be doing, but not a whole lot of like working together. It's more of just like telling them, oh, this is what I'm doing, and then just like taking that and then going and doing my own thing. So I think that even though that's what it initially was for me, I think that moving into it, it's more of like bouncing ideas off of each other and making sure that you guys are on the same page and having more continuation of care.
Great. Maybe one of the PT students, what about in clinical experiences? I think you've been to clinicals before, right? Yeah? You've been out? Yes? Okay.
Yes, we've had one clinical. It was more of an acute care, but yes, we've had a clinical.
Perfect. So maybe Nick or somebody else from your cohort, during your acute care clinical rotation, who are some people that you interacted with that maybe you talked to or you had a potential to talk to?
Well, I know for me personally, and I think a lot of people, we had a kind of a debrief that nursing was a big part of our communication. Just to kind of get, I was in an acute care where everybody was there for like 3 to 5 days, but you talk to the nurse and get an update on, how they're doing today, if they have any tests scheduled to kind of work your schedule around. And then we even had some conversations with the doctors to see, they wanted to talk to us to see how a patient was doing, post-operatively, to make sure that they were okay to go home, so that we were on the same page. So when they went and saw the patient, that they were giving a consistent message that they were hearing from PT as well.
Great. Yep. Thanks for sharing that. Anybody have any other experiences with maybe like social work or some type of other healthcare profession? Speech. Yeah.
I'll say something. So in my experience, a lot of it was PT, OT, co-treat. So at the hospital I was at, it was basically everything that we did every day was directly associated with the occupational therapist. We did all of our documentation in the same room. We treated patients together often. And like, I agree with what Nick said in terms of just like communication with the nursing staff and everything else. And I also think it's really important that with this interprofessional education that we're doing with you guys, that we gain a greater understanding of the scope of your guys' practice as well, because I don't think that we necessarily do that enough. Like when we chose to come to PT school, and so we learned just about PT. And so I think it's really important that going forward that we truly gain a true understanding of where there's overlap and how we can collaborate and do our own separate practices, but to, I guess, really give the best patient care. So I think that's going to be a really good, outcome from what we do with this.
Yeah, preach, Kyle. I totally agree. I think everybody in AT and the DAT that's finished school and been through professional education, the lack of people you actually talk to during your clinical experiences is crazy. So most of athletic training works in secondary schools or colleges, so high schools or colleges. And every place has a nurse or a student health center, but the lack of collaboration amongst even nurses in that setting is crazy. So I went through school not having one IPE experience, and so I really want to make sure that you guys both on both sides of the aisle here understand athletic training and physical therapy, because it's something that we got to make sure happens, and this is the best place to try it out. So one of the things, that last question here, I want to touch on, what do you think is the big push in healthcare? So as I said, I graduated, I guess, like 6 years ago now, and IP wasn't a big push, but now it's in all of our accreditation standards for CAPT and the CATI. So what do you think is the big push for us to include this for you guys?
I think
maybe just the amount of errors that one profession may have that could be easily caught if we collaborate with others.
Yeah, I was going to say, so going off of that, of what Annette said, I think it's a push towards that patient-centered care aspect as compared to a clinician-centered care. So now it's not so much focused on what's best for me, it's what can I do that's best for the patient. Sure. And a lot of times that it doesn't include me at all.
I will add that I feel like some of it is to kind of catch some people that fall through the cracks maybe a little better. We talked about assumption. If I assume my role and I assume somebody else's role, and maybe I'm assuming that they're going to do something, they're going to screen for some other pathology that they thought I was going to screen for. Well, now we've missed that pathology altogether, and so I think that interprofessional education, to know each other's roles and how they interact, to maybe give a more consistent message and catch those people that maybe fall through the cracks.
Yeah, Nick, I totally agree. And I'm not sure if y'all saw the chat Tim wrote in there, value-based care versus billing for services. And if y'all haven't taken a healthcare administration class or kind of kept up with the changing landscape of healthcare right now, that's my kind of specialty content expert that I teach in specifically, and it's changing. So we're going to go from a place that we bill for every single service to a place that we are billing for the patient getting better. And that idea that value care is going to be the new medicine. If you don't know, Amazon's getting into the healthcare market. They're going to have their own system online where people can sign up for Amazon Health, and they will be offering healthcare services through Amazon now. So we are really going to be changing how we're doing healthcare, and value-based care essentially says you won't get reimbursed for any of your healthcare services until the patient gets better. And so it's not just doing what you need to do to make sure that happens, but it's incorporating all aspects of that care team together. So the model that I would like to propose to you for success is collaborative leadership, that it's a natural phenomenon that emerges, that you have somebody that demonstrates leadership potential, but also demonstrates ability to be a leader, which means not telling someone what to do. That's a manager, but really invigorating ideas and supporting people through the process. Team functioning, obviously, creating authentic experiences. So once you become credentialed and you're out practicing on your own, you won't have an experience like this where we say, hey, you guys have to do this because it's required for your class. So how do you authentically do this and replicate what we're trying to model to you and accomplish collaboration? And that's when you have, if you know the scope of practice for each, you're able to take a step back and say, I can make an authentic experience out of this, that it's not forced, but it's a supplement, not a replacement of someone's care. Obviously, improve patient outcomes is the whole goal of what we're trying to do. And conflict resolution. You have to be able to talk to each other to resolve conflict and have that first difficult conversation without feeling like you got your feelings hurt. And making sure that you can be supportive of each other, but also critical of each other in terms of continuous quality improvement. All right, so some pictures here about some things that I think people do well for collaborative practice. So the first picture is a picture of Theo. So Theo was one of the doctors during the Ebola breakout. The Ebola breakout, no one knew what the hell they were doing during this. And people were scrambling to save people's lives. And what they found was that if people actually took a step back to find that the researchers, the clinicians, and the people on the ground in the countries listened to each other, they actually got a lot more done. So the people that understood the healthcare limitations or the disparities of the people within Uganda or wherever the outbreak was, If they actually listened to the people in the labs and said, I have a test that could work, you have to give it a shot. And then if you say, I'm willing to take a risk and let's work together to figure out how we can actually administer this drug and figure out if it works. So the Ebola breakout was a really a really interesting way to show how the communication collaboration can occur. If anybody likes TED Talks and from the DAT students, it's on your weekly videos. But there's a great TED Talk about how are we going to solve the next deadly virus. And I believe that that's how it's all going to happen. Like the measles, mumps, or the measles outbreak that's happening. I'm from Houston, Texas, and there's like 7 cases in Houston right now. We have to work together to figure out how we're going to fix that kind of idea of anti-vax and work together as healthcare providers to make sure that we're taking care of people that we necessarily weren't taking care of since the last big outbreak. In the NFL, this is a picture of an athletic trainer and a physical therapist working together on a on-field evaluation. The NFL actually requires that a PT and an AT both be on staff at any point. So when I was working with the Detroit Lions, you are required to have a PT and an AT, and they worked together, but they also knew where their limitations and where their specialty content stepped in for one person to take over versus the other. Obviously, 9/11, tragic events, mass casualties. You see people from all professions, firefighting, EMS, paramedics, throughout the first responders working together. First responders do a really good job at collaborating together, and I think that's a model that we can look at to see how collaborative practice works well. And specifically medicine, if you like documentaries, there's one on Netflix called Code Black. It's about an hour and a half long, and it's probably one of my favorite documentaries ever, especially as a healthcare provider. But this is a picture from Code Black. Essentially, Code Black's a term for where there's a wait in the ER for longer than 18 hours. And this happens often in county hospitals in California, and this details one specific county hospital in LA and takes it through how one big room, and by big room, like 354 where you guys have your lab classes, or like when you guys come to DAT week and we're in those classrooms together, that's about the size of their entire emergency room in this LA County hospital. And they place all these patients in here and have all these people talking at the same time, but everyone speaks the same language that they're able to accomplish patient goals together. And that's what I was talking about when you're speaking the same language. You don't have to say, what did you mean by give 20 cc's of what? Or you want me to do what with this adjunct? And you have to figure out what they're actually asking. People worked seamlessly together during that movie. And then in the military, as Dr. Hauser touched on, the military has a great medical setup. It's in terms of collaboration amongst healthcare providers, and athletic training's making their way into there finally. So the Air Force just created 35 jobs within the Air Force to hire athletic trainers. They have some in the Army already, and so we're starting to see that ATs are now starting to move into that setting for that collaborative practice to occur. Anybody have any questions so far about what we've talked about? Concerns? So we say this a lot in the DAT, but I'll say it to the PT students. Whenever I talk, and I'm sure Dr. Hauser talks too, we try to teach you about like being on an island, like perfect ideal state of this is what I want you to be like as a healthcare provider. And you may be over here in your boat. I'm just hoping that essentially you get on the boat and you start making your way over there. You don't ever get to the perfect ideal state of collaborative practice. That's okay. But you have to make the efforts in that boat to actually start doing some of those things. Because if you don't try to get in the boat and you just say, I'm not going to do collaborative practice, I'm good working on my own, you've essentially not tried. And so the best thing to do, or the biggest thing I can say to take home today is try to get in the boat and try to start doing the collaborative practice, whether that means talking to someone, Googling what a social worker does or a genetic counseling does, figuring out who another healthcare provider may be for a patient that you're working with, and looking at the state laws and then talking to someone that's in that profession. Anybody have anything to add?
I think it'll be interesting moving forward. I think a lot of us as PT students were involved in sports in high school, and whether or not you had a AT directly involved in that, you definitely built a relationship with them over the course of your tenure in sports. I mean, I know I certainly did with a couple of athletic trainers that I did.
Sure.
And so I definitely respect what they can do. And so I'm interested to see as we get some of those people that maybe are more active as youth getting into the profession, if that changes some of the willingness to collaborate.
I think that's a great point, Nick.
I kind of
Go ahead.
want to say on that, and I think we already kind of see that, because I think if you look at a lot of, at least in my company, we have a lot of PTs that had their athletic training as their bachelor's and their lead into physical therapy. So I think we've seen a lot of physical therapists who have advocated for athletic trainers just because of that base history. But I also think, at least as athletic trainers, we see it even in the coaches' perspective. A lot of those coaches who were former athletes respect a lot what that athletic trainers do, so it's helped us succeed. So it's one of those things that the more that we continue to advocate as athletic trainers about what we do, the more willing it seems like everybody else is kind of willing to come around and work together to provide a great experience for, at least in the high school setting, a great student athlete experience.
Definitely. All right, so I'm going to take you guys through what the rest of the semester is going to look like in terms of the collaboration that's going to be occurring. So this is the first time that we've done a group session together like this for our collaborations for the DAT, and I thought it would be a great time to kind of take you through what this is going to look like for the rest of the semester. So, computer, there we go. So as we said, there is our Zoom session. There are some podcasts that are available. I think Dr. Hauser has those links. If not, I can send them to them again, detailing what you can listen to some podcasts about PT and AT from a faculty perspective. And then in week 13, which is the second week of April, you'll do a roles and responsibilities meeting. So through Zoom, because our program is online distance, and so we'll have to meet through Zoom, but it's basically a guided set of questions about the roles and responsibilities of an athletic trainer and the roles and responsibilities of a PT. And you'll be working on 2 pairs of students, so there'll be 4 people on the call, 2 ATs and 2 PTs. And then you'll be also taking 2 tools for us about role clarity and the readiness for IPE. And essentially this meeting is going to be 45 minutes to an hour, and you're going to ask some questions, and you're going to have to be on the spot and respond to them. So you're going to need to know your profession really well and be able to answer some questions. You'll take this readiness or the role clarity tool first. It will have some questions specifically about the knowledge of how you become a credentialed PT. How do you get specialization in PT? What's the credential actually called? What's the route to maintain your athletic training certification? Those are type of things that help you understand how that person actually works and stays up to date. And so those are questions that if you take them and you have no idea, it'd be a good thing to write down to talk about in your meeting. But we also have some pointed questions for you to guide you in that process. That pair of students that you'll be working with, so you and the PT student, will be actually working together the week after. So you'll meet the week before with another group, and so it'll be 4 people total. That's just in case that people don't really understand the DAT or don't understand the DPT, that there's someone else to help you guide you in case you need a little nudge from a friend. But essentially that group will be split into 2 pairs. So in a pair, you'll come to your standardized patient encounter that will include medical documentation. So a standardized patient encounter, to kind of give you a background, the DAT students know this pretty well, but I was talking to Dr. Hauser and I want to make sure to touch on this. It's a simulated experience where an actor is trained to portray a case in a realistic fashion over and over and over again. So each of you will have a patient that is going to portray a case to you. You don't know that patient, and it's not going to be a friend from your class. It's going to be an actual patient. So they'll be trained to portray the signs and symptoms, answer your questions. If there's blood, bruising, broken arm, and it's there, it's meant to be there. If it's not there, it's not meant to be there. So it's literally, we can do everything to make it seem as real as possible. You just have to give it the chance to be real as possible. So you have to go into it thinking that this patient is real in front of you. The SP Encounter is designed to help you do whole person healthcare, facilitate IPE together. And so a Doctor of Athletic Training student and a DPT student will be working together for one patient. You'll collaborate on a physical exam, care plan, patient education, and an immediate treatment in 45 minutes. So you have to work together. We are not telling you who does the eval. We're not telling you who does the patient ed. You are meant to do it collaboratively together to accomplish the goal for the encounter. So you'll be graded on the SP evaluation tool, a content checklist, and a patient satisfaction tool. These are in the assignment rubric that both cohorts have been given. The SP evaluation tool is general concepts of being a healthcare provider. The concept checklists are yes, no on performance of certain skills. And patient satisfaction is the patient that's in the room will actually say how well they think you performed as a healthcare provider. So kind of give you a rundown of how it will work during week 14. The reason we're doing this during week 14, the program for the DAT has what we call DAT weekend, where we have a bunch of people come to campus. So all of our students that are distance and all of our local students come to campus for 3 to 5 days for hands-on learning, and that's part of our program. And so the students have to come at that point, and that's why we're doing it at that point in the semester. So we're going to go to Landsbaum. Landsbaum is the health center located by Union Health and Union Hospital. And we'll give you more information about where to specifically to go, so you don't have to feel lost. But you're going to arrive 15 minutes to your scheduled time. At that point, you'll receive a medical folder with some medical records regarding your patient you'll be seeing. You'll be able to review the case before you walk in and talk to that person live before you walk in. And you'll have 45 minutes together. And then at the end, you have 15 minutes to document together in one EMR system. That doesn't mean that the AT documents everything. That doesn't mean the PT documents everything. It means you have one EMR system. You have to work together to answer the questions. What we're going to do a little bit differently for the DAT students specifically is we're going to do two debriefing sessions. So we're going to do a small group with your evaluators. Your evaluators will be a PT faculty and an athletic training faculty member. We'll be watching it by video in another room. So you'll come to the simulation center and complete your encounter, and we'll be watching it by video. And then we'll be assessing it. And then with your people the two faculty that assessed you, all the people that had that person that day, we'll come in a room and talk about what they saw. And then as a group, we'll do a large group debrief with all 50 of the students and talk about collaborative practice, ways you can see this working in your future, ways you don't think this worked well, and in the case itself, and talk about it as a large group. So that kind of was a brief synopsis of the standardized patient encounter and what to expect. Usually this causes people to have a lot of anxiety and questions right now. So that's why we're telling you now, so you have over 6 weeks to prepare for that, but also left about 5 to 7 minutes here to ask questions about what that experience may look like. So if you guys have questions at this point, please let me know, and we'll be happy to answer those. No questions. So Dr. Hauser and I are going to wake up tomorrow with like 15 emails that says like, so just to clarify.
Or we'll just make the case a little bit more challenging. How about that?
So to give you context, we will not be telling you what the case is. You will not receive information that says this is going to be a concussion, and that's not going to happen. It's not a concussion. So you're not going to get information until that morning of 15 minutes before. So you can't study the night before. Don't feel like you need to be reviewing and studying that stuff. It's going to be things that you've learned throughout the semester, but cramming the night before for your SP encounter is just not smart. It's not going to be helpful for you in that process.
Did you see the question from Thomas?
Yeah, we have the group set in your pairs, so the people you'll be meeting with actually for the SP, and then the group of 4 people. I have contact lists made for all the email addresses, so you don't have to find them in the directory. So we have prepared that already for you, and we'll be sharing that as we get a little bit closer to that week 13 time.
I wanted to ask if there are going to be any limitations on the disorders or symptoms we'll see, like we have different types of cancers or maybe a heart attack, as that may have gone over in the past.
If you do, those are things you would need to ask the patient. I can't tell you.
Yeah. So essentially, this is going to be a complete evaluation from start to finish. So again, you're going to know, I think we're going to give them a little information about the patient. But other than that, I mean, you're going to have to evaluate the patient.
Yep. This is to guide you in that. Sorry, Jacqueline, I didn't mean to cut you off.
Sorry.
This is to guide you in that process of asking those questions that you may need to know, rather than yes, Marcus. Dr. Hauser and I have been talking about that, and our DAT students don't know what that means, but we'll fill you in a little bit closer about red flags. Go ahead, Jacqueline.
Oh, sorry. So Dr. Hauser, is this going to be more of like a direct access situation where they're just like coming in and we're just going through like a normal eval and like trying to figure out what's going on for them, or like a type of injury screen or something?
I would highly recommend, if you think of this as a direct access patient, absolutely.
Okay.
That you.
Okay.
So it's not going to be like my normal practical where I'm asking you the why constantly. This is going to be a real case and a real patient, and we want to see how well you can work collaboratively with AT students.
How much time will we have?
Yeah, and I think, Rachel, I think you're sharing your screen, just so you know. I can't stop it for you, Rachel, just so you know. There's a little green button at the bottom that says stop sharing.
It would have to be Rachel to do that.
Wasn't anything bad.
I'm just joking, Rachel.
How much time will we have with our partner before the SP to talk with them about what their skill base is and kind of collaborate in that way?
So the roles and responsibilities talk is to talk amongst yourself with your partner and somebody else about the professions, but also to gauge where their skill set is and where they feel the most comfortable. So we know that the DPT students are not credentialed, and we know that the athletic training students are credentialed, but that shouldn't guide you on that decision making. So you should be working collaboratively through this entire process. So not one person is more skilled to do this evaluation than the other. So you'll get that time to talk to that person, and then regarding extra stuff about themselves, you can talk to your partner outside, but the specific case, you won't get any information until 15 minutes before, when you arrive early to your encounter.
Do we get to leave the encounter and collaborate outside of the patient, or are we not allowed to leave before and talk in front of the patient, if that's making sense, where it's hard?
During your 45-minute encounter?
Yes.
So if you needed to step out of the room type of thing? Yeah, we're probably gonna allow that to happen as a natural evolution of the process. We would try, hopefully you would do most of your collaboration in the room, just because we were scoring it and we need to see you doing it because they're video recorded. So try to do as much as possible in the room. If there's something that you needed to do outside of the room, we'll try to discuss of how we're gonna be able to assess that, but we'll get you kind of more details on that, because I haven't thought about that process. If you need to step outside the room, I would hopefully try to do it in the room so we can watch it, because that's what we were trying to see, is what the IP experience is like.
So if it's like not natural in front of the patient, but we do it in front of the patient anyway, is that like?
You won't be graded off for talking about the patient with the patient in front of you, so you can collaborate. Okay. Yes. Does that answer your question?
Yeah. That's actually a really good question.
The Sim Center that you guys went to last time, we're not doing it at that one. We're doing it at an actual health clinic. So if you've been at Landsbaum, it's called the Molly Ringwald Clinic. It was a free clinic that used to be around here at ISU, but that's going to be the place. So it's actually set up as a healthcare clinic. It has all the stuff you may need, but it's large enough that you could walk to the corner and talk about the patient and then walk back in front of the patient, that there's enough room to navigate around the space.
Should we come prepared with like outcomes like we did in previous experiences, or will those be something a little bit different with this?
If you need something or want to bring something to the encounter, you're more than welcome to bring it.
Thank you.
I know that you guys hate when we do SPs, because we give you these vague ass answers like this, and you're gonna have to just do it again. So if you want to bring anything though, so supplies that you may need, so you don't need to bring like a goniometer to this. We'll have those things in there. So you'll have basic medical supplies like a Wartenberg wheel, a goniometer, different things like that.
Blood pressure
cuff, yeah. So you'll have all the stuff to do an evaluation and the immediate care plan. But if you wanted to bring things that necessarily wouldn't be in an office visit normally, so like a thermometer, like we'll have that kind of stuff. But if there's extra stuff that you like to do with your patients during your patient intake or evaluations that you've guided your practice or you've seen people do, those are things that you can bring.
And also, Zach, our students actually have clinician bags, and we will make sure they have to bring those
So I think that'd be a great thing for the PT students to discuss about what that looks like during your meetings with the DAT students, because they don't have that. No, you can't.
Who is Timothy Andrews?
Oh, Lord.
If he has one, please bring it.
All right. Any other questions related to the experience?
Will we need to have to try to provide outcome measures? Will those be given to us?
So yeah, all the outcome measures, that's what Devin was asking about in a roundabout way, because I know what he was trying to ask. If you need to bring any outcome measures or patient-reported outcomes, the tools that you need to use, feel free to bring your computer or paper ones that you may like to use. So if you have some general ones like SF-36 for health-related quality of life or things like that you want to measure, those are more than welcome to bring. There's some fancy websites out there like orthopedicscore.com that you could use that has them all built on a website that you could bring to the encounter too. So there's some options there.
It's weird how we started with the group chat being so professional, and look at it now.
Yeah. Good old DAT students.
You mentioned things that are out there, Zach, on the website. That sparked a question of if we will have internet access where we can point the patient to a website for further information after our appointment.
Yes, so you can bring a computer. The Wi-Fi access is ISU based, so if you have an ISU login, which all of you do, you can access the Wi-Fi. You can bring your computer with you into that visit too if you like to write notes or take notes. You'll be documenting online through an EMR system, so you'll need to bring a computer to that encounter, and we'll remind you to document.
Okay, but we can use outside resources while there. Okay, thank you.
Is this intended to be a clinical injury or illness, or is there a potential for an emergent situation?
I don't.
Oh, you can't say that.
Yes, we're not privy to ask.
Maybe you'll find out 15 minutes before.
So there is a potential, is what you're saying.
I'm saying that it's going to be based around things that have are going to combine your skill sets together. So if there's a potential for that to occur, we're not going to give you something that's outside the skill set. So you're not going to do genetic counseling during this and talk to someone about what's it like to live with Marfan syndrome. That's not going to be occurring. But there's going to be something where there is a overlap or skill set for you both to work together. So
cool.
If that's potential for PT, then that could be a potential for the case. Any other questions? All right, feel free. I'm going to put my email in this chat here too, so outside of all the funny comments people keep writing. But if you have questions, Dr. Hauser wrote his email in there earlier, and I have my email in here too. If you have questions specific to the SP encounter, you can ask Dr. Hauser or I, and we'll help guide you through that process, and then we'll be chatting again in week 13. I'll be sending out this recording to Dr. Hauser, and he can share it with you guys then. But if we don't have any other questions, I hope you guys all have a great night, and yeah. Thanks for joining.
Thank you.
Thanks, Zach.
Yep.
Thank you, everybody.
Sorry again, everyone.
It's all right.
You cannot help it. You cannot help it.
I don't know what I did.
You press share screen.
What was it?
Sorry, I started the chain of unprofessionalism.
It's all right too.
What was it? I don't even know what I had up.
So there's
It's
a
okay,
green button at the bottom that says share screen, and it was just your like Zoom website. So thanks. That was all that was there for you, Rachel.
Oh, gosh. Okay, good.
Have a good night.
No, don't worry.
Zachary.
Hey, Zach. When should I expect information about this?
Oh yes. Yes. So I forgot, Dr. Hauser, that we have students that aren't in the first year cohort that's going to be working with us. Remember, because we have odd amounts.
Oh yes. Yeah. That's
right. I'll email you. I'll email you, Nick.
Okay, sounds good.
Right. Cool.
Thank you.
Any of you guys have questions that are still on?
Oh, and thank you, Marcus, for adding the APTA Code of Ethics. I know you've had that before in Intro to Physical Therapy.
Any of you guys have questions? No? All right. I'm going to end the meeting then. You all have a good night.
Thank you.